Good evening, everyone. Good evening, esteemed colleagues and healthcare professionals. I'm Dr. Anjali Joshi, your host for today's critical discussion on poisoning, which was made possible with our collaborating partners, Poison Information Center, Nepal Medical Association Junior Doctors Committee, Ask Foundation, TU Teaching Hospital Institute of Medicine, and Brown University. It is a privilege to have all of you, the dedicated experts in our field, joining us. In the world of healthcare, we encounter poisoning incidents that demand swift and informed responses daily. Today's webinar is designed to deepen our understanding and refine our skills in managing poisoning cases, and also familiarize ourselves with the Nepal's first institution-based Poison Information Center. As healthcare professionals, we play a pivotal role in saving lives and ensuring the well-being of our patients. This webinar will provide us with the latest insights and evidence-based practices and expert guidance to enhance our ability to diagnose, treat, and prevent poison-related incidents. Our esteemed panel of experts, Dr. Ramu Kharel, Dr. Jonathan D. De Olano, and Dr. Rakesh Ghimire will share their invaluable knowledge and experiences, and we encourage active participation and questions from our fellow professionals. So whether you're a seasoned toxicologist, an emergency room physician, a nurse, or a pharmacist, you are here because you understand the critical importance of staying at the forefront of medical knowledge. Thank you for your commitment to the health and safety of our communities. And without further delay, let's commence this enriching journey together. I would like to welcome Dr. Ramu Kharel. Dr. Kharel is an assistant professor in emergency medicine at the Albert Medical School of Brown University and serves as the Nepal coordinator for the Center of South Asia at Brown University. He received his medical doctorate from UT Southwestern in Dallas and his master's of public health from Harvard T.H. Chan School of Public Health. He has also completed focused subspecialty training in global emergency medicine research and clinical tropical medicine and hygiene. He works clinically in the United States as a practicing emergency care physician and also undertakes global health research focused in Nepal. His research focuses predominantly on improving emergency care systems. He has worked extensively in 2015 Nepal earthquake response, recent COVID-19 response, and continues to engage in Nepal in variety of work to improve emergency care and public health response to disasters. Recently, he also led the establishment of the first institutional Poison Information Center in Nepal, which is based at TU Teaching Hospital. Dr. Kharel is also very active in social media, mostly teaching public health measures in the face of population disasters, and goes by the name Namaste Doctor. He's also a fan of basketball and Urdu poetry. Now, without any further delay, I would like to request Dr. Kharel to commence today's session. Thank you.
Wow, thank you. Thank you, Dr. Anjali. That was great. Thanks for that very kind introduction. Can everyone see this, hear me okay? All right, perfect. So if you guys have any questions during when I'm talking, I will have time for questions at the end, but please just write on the chat and maybe Rajesh, you'll let us know if there are any questions. But today's sort of schedule is that I'll talk for 10-15 minutes, and then we'll have Dr. Jonathan De Olano, who is a medical toxicologist from Emory, who will be giving a presentation, as well as Dr. Rakesh Ghimire from TUTH, who will be giving a presentation, and then we'll conclude. Again, thank you so much, Dr. Anjali, for the introduction. Like you said, I'm an assistant professor in emergency medicine, and I have a deep love for Nepal, and I'm interested in improving emergency care systems in the country. So today I'm going to introduce the Poison Information Center to you guys, and I'll kind of give you the model of it and what we are doing and how this can be helpful for medical doctors in Nepal. All right. As you mentioned, I do go by Namaste Doctor, so some of you might know me as Namaste Doctor. So 2021, the government, the Nepal government, put out a report called ECSA, which is an emergency care system assessment. And part of that assessment, they identified 39 key priorities to improve emergency care. And one of those priorities was, as you can see here, number 11, was to develop a strategy for a government-run national poison control center for providers and the public. Now, some of you might already know there is a nonprofit organization that has been sort of running a poison phone line in the past. So I do want to acknowledge that that did exist in the past, but we don't have an institutionalized poison center, and looks like it's a government mandate that we do need to create a national and institutionalized poison center. So this is what led us to come up with this project of establishment and assessing a institutional poison center. And this is sort of a pilot feasibility study, but we are providing services, and we're hoping that this feasibility study goes well. Now, I don't think I need to convince anyone here that's joining the burden of poisoning in Nepal. Can somebody write, can you folks just put on chat, what is the #1 cause of poisoning in country? Or you can unmute and speak also. It's pretty simple. I think you all know. There you go. Organophosphate, Dr. Raj Mandal said, right? Like we have, and over the last few years, we've been having rising medication overdoses like paracetamol, salicylates, anti-glycemic medications, antihypertensive medication. So there is a large rising burden of toxicology cases in the country, apart from organophosphate as well. And of course, you all know snake bite is a large burden in the country. I think I'm seeing some chats with everyone saying OP, right? So that's fantastic. So what is the overarching goal of this Poison Information Center? It's really two goals here. One, we want to provide specialized advice on diagnosis and management of poisoning patients. It doesn't matter the age, the agent. There's thousands of poisoning cases that can happen. So we want to provide this expert advice, one. And two is to really promote cost-effective and evidence-based management of poisoning, and especially avoiding unnecessary and ineffective treatment. Of course, the PIC has health and economic benefits, which have been well documented by our government, by the WHO. One, it reduces delays and delivery of care. It reduces, and then reducing exposure can also reduce morbidity, mortality. It also has economic benefits, right? Someone from a remote village that could be observed there, that doesn't need transfer, doesn't need to waste all that money to come to referral centers, right? If we have good referrals and a support system available. So there is a clear benefit to this. So how did we form this partnership? I just want to give you all a background of this, so you have an idea of how we are functioning. So this all started through a small grant that I got through Brown University. I'm a faculty here, and I'd applied for this grant after I saw the poison, sort of the need for Poison Information Center in Nepal from the government assessment that I mentioned earlier. So Brown University, my university, serves as the sort of primary international partner, and we partnered with two sort of institutes in Nepal, TUTH or IOM, the Clinical Pharmacology Department, and led there by Dr. Anish Marwari, who might be in this call, and Dr. Rakesh Ghimire, are the primary implementing partners. So our PIC lives within the Clinical Pharmacology Department at TUTH. I'll show you some pictures in a bit. And that is the primary sort of partner in Nepal for implementation. And then we have a nonprofit partner that's supporting us with logistics and sort of getting this moving forward within the country, and that's Ask Foundation. And then we also have an education partner along with Brown in education and research, which is Emory University, which is also my alma mater in the past. But one of my mentors is from there, and you'll hear more about that in a bit. So this is sort of it looks complicated as far as model, but we really need this international support, one, because we don't have many toxicology experts within the country, and two, our burden is really high, and what our goal is to also capacity build within the country so that we can sort of be hands-off a little bit later. So how does this work so far? Just this conceptual model. Any phone call from a healthcare provider, if you're working in a health post, a primary health center or a tertiary center, if you have a suspected case of poisoning or a confirmed case, you can make the phone call, and I'll tell you what that phone number is in a bit, so you can save it in your phone. So when you call the phone line, our expert spies. They're called spies, specialist in poison information. We have 3 spies that have been trained very thoroughly, one by Emory, and they continue to get training management through a Harvard program, and they take course on a longitudinal basis. So these are medical doctors who have been trained to answer your toxicology questions. They also have database available to them. We have a database called ToxBase. They have PIC protocols that we have made. They have other resources like the Gold Frank books and things like that. So they have all the resources to answer initial questions that you might call about toxicology case. Now, if they can't answer those questions, what they will do is they will have a national list of experts they will ask for consultation advice once they hang up. And then if the national list cannot answer, then we have an international list that includes myself and folks from Brown, folks from Emory, and other folks that are a medical toxicologist in the country. So we have a really nice layer of support to provide evidence-based medical toxicology support line for doctors working in all sorts of settings. And then once they answer that phone call, they'll provide you the recommendation. But it is to be noted that the final healthcare decision belongs to you, the person who called, right? That's your patient. We're just providing support and advice and help as needed. We're also collecting some data on the type of poisoning, if this actually works, if the spies actually used an international expert, a national expert. So we also want to convince the government that this type of model can work, and we're kind of testing to see if this works. This is just one of the trainings that our spies went through. And this is sort of the list of the lectures and the topics that they went through. So I just wanted to share that with you here. So what is our phone number? So this is when I ask you to take out your phone and save this phone number. The phone line is currently available from 9 a.m. to 12 a.m. But we are going to have 24/7 availability coming soon. So please save this number. And any suspected case, it doesn't even have to be a confirmed case. If it doesn't even have to be something that you are sure about. If you're unsure and you think that there could be toxicology case, then please call this number, because one, that will help us understand the type of epidemiology in the country that you are all seeing, and to help us create protocols and resources for that. And then two, it will help us guide you in any ways and stay anticipatory guidance, meaning that if it is a poisoning case, then our team will be sort of more ready if you call as soon as possible. So so I please request you to jot this number down: 01-450-2011. I'll give you 30 seconds to jot. So just to summarize this, we know that toxicology consultations are effective. They've been effective all across the world, and we know there's a big need in Nepal, and that has been put out by the government, by the WHO, and that's why we're establishing this new sort of the first institutional poison information center in the country. We're also trying to collect data on epidemiology, and really for long-term sustainability, what we are trying to do, hopefully, if this is useful for you guys, our goal is to convince the Ministry of Health that they need to run something like this, right? Like they need to have a 24/7 support hotline for you. So we're trying to show them how to do that. Now I'm going to end with, before I introduce our next speaker, I'm going to end with a few pictures and maybe some cases that I have seen. So can anyone here, you can unmute yourself, name what this is. You can give me the Nepali name.
Dhatura.
That's right. Who said that? Dr. Dhiraj?
Yes.
Okay, Dr. Dhiraj, what is the toxidrome of this? Have you seen this?
I have seen.
Yeah, basically this has a lot of sort of atropine-like and scopolamine-like, right? So you get anticholinergic effect from eating this. I know, I think when I was young, this was in my village also, and I remember eating some part of this, and you get a nice high, right? But then if you take too much, then you'll get severe anticholinergic effect, and you could potentially die. So this is Datura strabomium or something like that. That's the chemical name. What type of snake is this? Somebody else besides Dr. Dhiraj. You can type in the chat if you can. I saw this, to give you a background, I saw this snake while we were sitting down at Bailpata Hospital in Assam. We were just sitting outside, and then this just sort of came across there. Viper, that is correct. It's a viper. And more specifically, what I think this is a Himalayan pit viper. And I just want to sort of give you this nice way to figure out the type of snake, right? Like between the vipers and the Elapiid family, there's a really easy way to identify these things. First, you look at the head, right? The vipers have a triangular head that are distinct from its body, whereas the Elapids, which are the kirats and the cobras, right? They have almost an oval head and the head that's continuous with the body. And I'll show you some pictures. And the vipers are relatively short and thick, and they have a smaller tail, whereas Elapids are slender, long. They're kind of very cool, right? Like they're cool and slender going around. They have a longer tail. The vipers have rough scales in their body, whereas Elapids have smooth scales. So this is how you can really easily identify between, right? Like these are the vipers. These are the vipers we see in Nepal. The Glodius himalayanus, which is the Himalayan pit viper, you can see there, and then the green pit viper also, that you can see on the left side. And then these are the Elapids, right? So you see this like very difference, right? So this head, it's kind of triangular and kind of separated, almost like a coming out of the body. Whereas if you look at this head, this is sort of continuous with the body. And you see how smooth and slender these look, right? This is the kirat. This is the naha, right? This is the cobra. So that's a brief way to kind of differentiate this. Now I'll just leave you with a few pictures. This is from our first meeting at TUTH. I mean, as you can imagine, establishing something like this has taken us more than a year and a half of work, a lot of work in the background, a lot of agreements and things like that. We're very happy that TUTH has agreed as a esteemed institution to help us be the implementation site of this. So this is the team, clinical pharmacology team. Here we're with the dean, as well as Dr. Pradeep Gewali, who is from the NHRC, who has helped us quite a bit in moving this forward. You can see Rakesh, Dr. Rakesh Ghimire, and myself as well. This is the same thing I presented to you today. I was presenting at TU when we first started. This is Dr. Ziad Qazi. He might not be here today because he's flying from Turkey, but he's been he's a medical toxicologist at Emory, and he's been helping me sort of guide through this. As you know, I'm not an expert toxicologist, but so we all need support in the background. And this is our core team that's Kavin Maleku from AS Foundation. This is Rakesh Ghimire, who is representing TUTH, and myself. Numerous meetings while eating momos, of course, to make this happen. This is how the PIC looked when we first sort of saw the room, how we're going to get it. This is how it looks now. Good job. Our spies are doing a good job getting this going. And this is one of our spies, Dr. Aishma, who is here also, that is there to answer your phone call at all times. So I will leave you with this, and I'm going to introduce our next speaker. Can somebody tell me where this is? If you know. All right, let me play that video again. All right, I think this is a hard question. So this is at Kaptar National Park, really beautiful up there. So I'm gonna stop sharing my screen. We'll do question and answers later, so save your questions for later. I'm gonna ask Dr. Olano to share his screen, and I'm gonna just introduce him while he shares the screen. So Dr. Olano is an assistant professor of emergency medicine and medical toxicology at Emory University. He graduated from medical school at Emory with AOA honors. He did his residency and fellowship in emergency medicine and medical toxicology at NYU and Bellevue and the New York City Poison Center. And now at Emory, he works at Grady Hospital, which is my alma mater as well. And he also works at the Georgia Poison Center. He was a John Stone Award winner for teaching at Emory. He's a great teacher, a wonderful friend, and I've known him for a number of years. And he is going to be talking today about how to generally approach a poisoning patient. So a very brief general overview of this, and we're hoping that Dr. Olano and his team at Emory continues to be engaged with our Poison Information Center. So please, Dr. Olano, take over.
All right, thank you for the introduction. Can you hear me? Is that okay?
Yes, we can hear you.
Okay, wonderful. All right. Again, thank you again for the honor to be able to present here. I'm excited to talk to you all today about the approach to the intoxicated patient. And I only have about 20 minutes to go over what is going to be a large amount of content, but really it's going to be looking at the actual approach to how we deal with anybody coming in with a suspected poisoning, a suspected ingestion, and try to create some sort of framework for us to then take care of that patient, right? So let's see if I can get this going. All right. So in terms of our objectives today, we're going to look at three major things. We're going to look at the approach to the initial emergency management of patients with suspected poisoning. We're going to use our physical exam to determine the overall class of drug ingested. And then we're going to discuss, based off of that, some basic management strategies. But the beauty about toxicology is that it's your physical exam that helps you determine, for the vast majority of cases, what kind of ingestion it was. And even if you don't know the specific drug, as long as you can put it in a class of drugs, then you can figure out the management of that patient. And ultimately, we're going to look at, one of our most useful tools as toxicologists is looking at how do we decontaminate patients with suspected overdoses. Now, part of the beauty about toxicology is that anything can be toxicology. A patient who is altered, acidotic, alkalotic, hyper or hypotensive, a screaming patient, a sleeping patient, basically any clinical presentation can be a poison patient. And if we think about just in terms of drugs, how drugs typically work, they are hitting already established receptors in our body. So it's an augmentation of the human state in one extreme or another. Right? So things that are going to be important for us to know the moment a patient comes in are the who, what, when, where, why. So, and this is going to be important information that when you are calling a SPY or a medical toxicologist, this is the kind of information that we would like to know. So what's the patient's age, pediatric patient, adult patient, their weight, the doses of the medications that they may have taken, whether the ingestion was a single ingestion, whether they were multiple ingestions, and this is particularly important with paracetamol or acetaminophen. The type of exposure, so if it was a dermal exposure, ocular exposure, oral exposure, inhalational exposure, and the geographical location in which this occurred. As we see in toxicology, as you guys have already pointed out already, in Nepal, organophosphates are being one of the most common sources of exposure. Those are not as common in the United States, and so toxicology is very much kind of geographically based. Thankfully, we don't have COBRAs either. And then whether or not the exposure is a intentional exposure or unintentional exposure, and we can think about this as being a risk factor in terms of severity of illness if the ingestion was intentional versus, say, a child who has an exploratory exposure to a medication that they might have found on the floor, for example. It's very different in terms of the dose that they might have taken versus someone who's trying to actually harm themselves. So more in terms of history, things that we can, or people that we can obtain a history from might be the patient, although oftentimes they are unreliable, whether they don't want to tell us or they are in a psychological state that they're not able to communicate with us. Their friends, families, and what empty pills that might have been found by the people who brought the patient to the hospital. Other things that are helpful are their past medical history. So just understanding that the patient might have a history of, say, bipolar disorder may put them at risk for having access to medications such as lithium or valproic acid, other mood stabilizing drugs that they might have been exposed to, as well as occupational or environmental exposures. So we use what's called the ABCs of toxicology to initially stabilize a patient who comes in after an intentional ingestion or after an ingestion, and that's going to be the airway, breathing, circulation, and then typical emergency medicine. But then we're going to talk about diagnosis, decontamination, and elimination. Now, some drug exposures have an antidote, some do not. Some of them we have to basically treat supportively. And lastly, G is going to be for get a tox consult, or in our case here, we can talk to the poison center or a SPI for further aid. Along with airway, we do want to check a glucose and determine whether or not the patient needs to be intubated or supported from their ventilation standpoint. So now let's talk about what our physical exam is going to help us determine. As we mentioned kind of before, the physical exam is key into determining what type of class of drug they might have ingested. So this is going to require a complete set of vital signs, and the large part of the rest of the lecture, we're going to talk specifically on each vital sign and how each one of those things can give us insight into the type of ingestion. Their mental status. So are they altered is not enough, right? Are they agitated? Are they obtunded? Are they picking at little things? So something like anticholinergics, as the plant that Ramu showed earlier. Anticholinergics are notorious for people picking at small little things as they are having a specific type of hallucinations. What's their skin like? What's the color, the temperature? Are they sweating? Are they dry? What are their pupils doing? Are they dilated? Are they reactive? Are they not reactive to light? And this is also one of the few times in which you actually take out your stethoscope and listen for bowel sounds. Is there a presence or an absence of bowel sounds? And what is your bladder doing? And lastly, their neurological exam. So checking their reflexes and if they have a tremor, such as an lithium overdose, or do they have clonus, where you dorsiflex their foot and they have clonus of their foot, right? Clonus is a sign of neuroexcitation, and in toxicology, we tend to use it to look at signs of serotonin toxicity. Unlike animals that use serotonin as part of their motor function. If you think about, say, a dog coming out of a bath and a dog kind of wiggles around and shakes, that is all serotonin mediated. In humans, we don't really see that unless there's excessive amounts of serotonin. Hence why we can see that neuroexcitation in the I guess the presence of clonus on exam. And this physical exam finding is going to help us determine, again, the class of drugs, and specifically looking at things like receptors that are hitting different types of or different chemicals that are hitting different types of receptors that might give us an idea of if I have too much of a sympathetic response, parasympathetic response. Am I having neuromuscular weakness or paralysis, say, from a nicotine exposure or an organophosphate exposure? All of this is going to help us determine that. So now let's spend time looking specifically at vital signs and an EKG and a finger stick to see how we can break down this a little bit further. Now, when it comes to toxins affecting blood pressure, one of the things is that you might have a hypotensive patient. Now, there are only four general ways in which toxins can lead to hypotension, whether it's a decrease in systemic vascular resistance, so whether this is due to peripheral vasodilation, whether they took something like an alpha antagonist, like a tamsulosin overdose, whether they took a calcium channel blocker overdose, and you can see things like alcohol even can lead to peripheral vasodilation, hence why people's faces get a little bit warm when they drink alcohol, right? How are these patients going to present? They're going to present in extremis, if they take too much of this, they're going to look like a vasoplegic shock patient. And again, what we're going to see is primarily going to be vasodilation here. Now, you can also get hypotensive by having decreased intravascular volume. So whether metals are notorious for causing this, such as iron, that lead to ongoing emesis, and that leads to a decrease in your overall blood volume, and that leads to hypotension. Alcohols can also do this. And cholinergic toxicity, so your organophosphates may also lead to profuse amounts of loss of stool or emesis, and that can also lead to hypertension as well. Now, these patients are going to present like hypovolemic shock, right? They may be on exam cold and dry on exam, right? Except for, again, the cholinergic patients. And then the last way we can have is specifically more cardiogenic in nature. So whether that is due to a decrease in ejection fraction or dysrhythmias, as mentioned through these list of medications here. We have a bunch of cardiotoxins, antidysrhythmics as well, but there's also mitochondrial toxins. So things like cyanide, which is probably the most extreme version of this, that leads to cardiovascular collapse, right? But these are going to be main ways in which, the four major ways in which blood pressure may be affected. Now, on the other extreme, we can see hypertension, right? Excessive catecholamines, excessive excitation, things like sympathomimetics, anticholinergics, inotropic drugs can all lead to an increase in my blood pressure. Interestingly, things like clonidine, which is typically used for treatment of high blood pressure, if you take too much clonidine acutely, what you're going to see is the early alpha effects, and they're going to present hypertensive and bradycardic before they become hypotensive eventually. So now let's move to heart rate. Now, we can have patients that are tachycardic or bradycardic depending on the ingestion. It's important to try to differentiate, is this due to the drug itself, or is this a compensatory mechanism that's leading to the opposite effect? So let's use a kind of just basic physiology here. How do we develop a tachycardia? Right? So we have impacts on the funny channel, right? The sodium-potassium channel here that increases leak into the cell that leads to depolarization. The way in which we get this increased activation of this channel is by beta agonism. So anything that leads to ultimately beta agonism, you're going to have tachycardia. The opposite would be true. You have bradycardia with acetylcholine, but if I block acetylcholine with an anticholinergic, or as we say, antimuscarinic, that will also lead to tachycardia. So we're going to see this with caffeine, sympathomimetics, anything again that leads to an increase in your heart rate. And I alluded to this earlier, but the opposite would be true for things like acetylcholine. Excessive amounts of acetylcholine will lead to bradycardia. Here we have foxglove, which is a beautiful flower, or digitalis. Digoxin's bradycardia comes from that increase in acetylcholine. We also have L-type calcium channels here that might, when blocked, that will also lead to bradycardia, hence why drugs like diltiazem and verapamil all lead to that bradycardia. And this is just an example of a digoxin overdose where we have pretty significant bradycardia due to the acetylcholine effects from digoxin. So interesting things that we could do to the heart in terms of every toxins that patients might be exposed to, we can do a lot of different things. So this is just an action potential that we're seeing here. We can excite the heart by exciting this action potential by drugs like digoxin or sympathomimetics. We can increase that heart rate by causing things like beta agonists, again, acetylcholine antagonists or antimuscarinic drugs. We can suppress that heart by things like adenosine or excess amounts of magnesium, right, making it more difficult to depolarize. And as I mentioned just before, we can slow down that heart, whether that is because I'm blocking the beta receptor, blocking calcium channels, or increasing the amount of acetylcholine. Interestingly, severe hyperkalemia due to its sodium channel blockade effects may also lead to bradycardia. So I'm going to give you an example here of an EKG, and this is a classic tricyclic antidepressant overdose EKG. You can quickly see that the patient is extremely tachycardic. Now, why are they tachycardic? Could it be from the anticholinergic effects of the TCA? Possibly. Could it be related to some endogenous catecholamines as a result of ingesting a TCA? Now, what we're seeing here also is that we can see a wide QRS with a positive deflection in AVR. This is going to give us a hint in terms of the effects of a drug on the heart. Whenever we see a wide QRS with this positive deflection, I want you to think about a sodium channel blockade. Again, tricyclic antidepressants, classically known for causing sodium channel blockade. And again, we see this deflection of our sodium channels that leads to a widened QRS. Unlike potassium channel blockers, which will lead to prolongation of the QT. So if sodium channel blockade is the problem here, we're going to treat this with giving them sodium bicarbonate. And now what I want you to see, difference from this EKG from the last same patient, the only difference that we've had is that we've given this patient sodium bicarb. Now, I think hopefully we can all see very quickly that the QRS here is narrowed, right? More so than before. And I also want you to see that the heart rate has decreased, right? Again, this was the EKG from before, very tachycardic in 160s. Here, the heart rate's come down to 120s. So, as a result of getting sodium bicarb, what we're actually doing is that we're improving the cardiac function and overall squeeze of the heart, and therefore my catecholamine response to a decrease in ejection fraction has now improved, and so my heart rate will come down as a result of that, which is quite impressive. And this is just further sodium bicarb in time, and you can see that the QRS is narrowed and the heart rate has slowed down as well. Now, there are going to be times in which you can see sodium channel blockade that's so excessive that it itself will lead to bradycardia. Hence why a lot of times hyperkalemic patients present with bradycardia. This is an interesting case of a gentleman who came in complaining of not, quote unquote, not feeling well, had this EKG done, and immediately had a seizure. And they had a seizure and then went into cardiac arrest. While they were doing chest compressions, they noticed there was a package coming out of his rectum. And it turned out that he had, they're able to give, based off of this EKG, 4 ampules of sodium bicarbonate. They got ROSC to this patient, and they did a CT scan, and hopefully this shows up, but they found in his intestinal tract hundreds of packages, neatly packaged packages of cocaine. So this is an example of a massive cocaine overdose, which we typically think of as causing tachycardia, right? But when you have too much sodium channel blockade, this will actually lead to bradycardia. And we can see this with things like flecainide and propafenone, right? But a nice reminder for us, heart rate, well, why is the heart rate going fast or slow? What is the EKG demonstrating to us? That can give us some insight into what the patient might have ingested. And this is a fun paper that from my mentor, Bob Hoffman, out in New York City at the New York Poison Center, in which he gave, basically showed an animal model in which if you give a rabbit cocaine, they are tachycardic. If you give them too much cocaine, their heart rate actually slows down, right? And then if you give them the antidote, which is sodium channel, it's a sodium bicarb, their heart rate speeds up again, as you can see in the last 2 lines here. So respiratory rate. Why is a patient tachypnic or hyperpnic, meaning taking deep breaths, or why are they bradypnic? Why are they taking shallow breaths or not breathing well enough? Is it due to a compensatory metabolic acidosis? Is it due to increased energy utilization? Say that they took a bunch of cocaine or methamphetamines, and they're increasing their energy utilization, and that's leading to that tachypnea. Or is it due to direct stimulation? So salicylates, aspirin, for example, is notorious for causing a respiratory alkalosis. Methylxanthines, things like caffeine or theophylline, also are known for causing direct stimulation. On the other extreme, is it because they have something that is preventing them from breathing, whether it's due to a paralytic, due to the, say, end stages of organophosphates? Is it due to combinations of sedative hypnotics or opioids, right? Now, if we spend a second here talking about metabolic acidosis, it's important to try to figure out what that source of the metabolic acidosis is from. Is it due to, the quick mnemonic that we use is Colts, or you might have heard of things like mud piles, but everything can be distilled into anion gap metabolic acidosis. Is it due to ketones, uremia, lactates, toxic alcohols, or salicylates? Temperature. Again, a lot of insight can be brought by if there's a dysregulation in your temperature. Are they hyperthermic? And this is particularly important for people who are using sympathomimetics or patients with serotonin toxicity, NMS, or malignant hyperthermia. All of these are due to excitation, exertional hyperthermia, right? It's that psychomotor agitation that ultimately leads to that increase in temperature. Or is it due to something that's non-exertional, something deeper, right? Something here with uncoupling agents such as salicylates or dinitrophenol. So if you check someone's temperature and say that's very high, and you look for muscle rigidity and they have no muscle rigidity, they have no clonus, they have no, again, psychomotor excitation, maybe it is something like a dinitrophenol that's causing this elevated temperature. Now, on the other extreme, hypothermia, right? This is not as commonly seen, but with some rare exceptions, if you have environmental exposure, so say that you take something like a sedative hypnotic, an opioid, or even alcohol, and you're just exposed to the environment, that may cause hypothermia, fine. But there are drugs that cause central hyperthermia, such as NSAIDs, non-steroidal anti-inflammatory drugs like ibuprofen. Massive ibuprofen injections may cause that. So last group we're going to look at is just oxygenation. Why is my oxygenation status normal, or why is it abnormal? Am I hypoxic because I'm hypoventilating, such as an example of a opioid overdose? Am I hypoxic because I have a diffusion impairment? This is a cadmium pneumonitis, so some exposure to cadmium to the lungs that's lead to problems with a VQ mismatching. Or is it due to something else? Is it due to a hemoglobinopathy where my oxygen saturation on the monitor shows 85%? I give them oxygen, it's still 85%. I draw blood and I notice this kind of chocolate colored blood. Maybe it's actually not due to an oxygenation issue. Maybe it's due to a hemoglobin problem, such as methemoglobinemia. So just by looking at all these vital signs, we can kind of come up with a list of different toxins that might explain just abnormal vital signs. I'm not even talking about exam right now, just the vital signs. So this is, I think, an impressive list just by looking and spending an extra moment looking at their vital signs. Now, the last things that we're going to talk about right now is, tox syndromes, which is, again, a way in which we can categorize different ingestions. And while there are more than 5, these are kind of the 5 standard ones that we can that we like to might be the easiest to kind of discuss. So things like sympathomimetic overdoses, whether it is an amphetamine, a cathinone, cocaine overdose, they're all going to present high blood pressure, high heart rate, high respiratory rate, high temperature, which is going to be the most important thing, very dilated pupils, very diaphoretic, and flush. Anticholinergics, on the other hand, they're going to present kind of similar to sympathomimetics. They're going to have an elevated heart rate because of the anticholinergic effects on the heart. They might have an elevated temperature from their inability to sweat, and their pupils will be dilated, but unlike sympathomimetics, they will be unreactive to light. And then if you check, say, their axilla for any moisture, you'll find that they're very dry. Cholinergic drugs, which I think everybody on this meeting seems to be very, has many examples of, like organophosphates, their blood pressure and heart rate might actually be a little bit on the lower side, especially towards the end. But the big thing here is that their lungs are going to be filled with fluid, they're going to be diaphoretic, they're going to have myotic pupils. Opioids, everything is down. Blood pressure, respiratory rate, heart rate, temperature even, and pupils are going to be very, very small as a result of an opioid. And sedative hypnotics, the interesting thing about them is that for the most part, they're typically going to present with normal vital signs and increased amounts of sedation or obtundation. So patient comes in for a suspected ingestion. These are going to be the tests that we want to obtain on everybody. And while I've mentioned a lot of vital signs and physical exam findings to pinpoint the toxin, there are some tests that we have to do on every overdose patient, and that's going to be an acetaminophen level or a paracetamol level. And the reason here is that paracetamol, unlike these other drug exposures, the initial clinical presentation is that patients are going to be asymptomatic. And we can see this actually with some liver poisoning, such as amatoxins from amanita mushrooms. You're initially not going to have any symptoms and then develop the abdominal pains, or then develop emesis, or then develop abnormal, vital signs, etc. So that is going to be one that has to be drawn on anybody who's suspected of an overdose. One other thing I want to point out is that in the United States, at least, a lot of people draw urine drug screens to try to determine the source of their intoxication. And I want to affirm with you that there is no role for urine drug screens in the setting of acute toxicity. What matters most is your physical exam, because urine drug screens can tell you what the patient may have taken over the course of the last few days, but they don't tell you what's happening at the moment. And that's where your exam comes in. And in fact, we just had a child yesterday that we were called in because they had a positive PCP and positive opioid urine drug screen in a 2-year-old. And it all turned out to be a false positive from diphenhydramine or Benadryl ingestion. So in terms of decontamination of these patients, we want to make sure that we remove clothes, we want to irrigate eyes, we want to remove the patient from the source of exposure if it was an inhalational thing. We're not going to talk too much about this, but we're going to spend more time looking at GI decontamination, the role for activated charcoal. This is going to be our major tool to prevent that drug that is, say, already ingested into the GI tract from it getting absorbed to the body. Now, the major risk factor to giving charcoal is aspiration pneumonitis. So patients who are tunded, they cannot get this. So, but if a patient is alert and oriented and is able to have able to drink a solution, activated charcoal should be given. And it should be given hours and hours after the ingestion. There's not a cutoff on when we would give it. There have been times I've given charcoal even 12 hours after an ingestion. Now, there are several cases in which you wouldn't give charcoal, and they're listed here. Caustics, hydrocarbons, these are things like fuel, sticky oils, alcohols, metals, leads, and salts. All of these, you cannot give charcoal, but every other xenobiotic or drug, consider giving charcoal early on to prevent further absorption. There are other modalities that we can also use, but again, the primary one is going to be activated charcoal for most of our intoxicated patients. Now, I want to briefly just talk about acetaminophen, and I think we're finishing up right now. And I want to, again, emphasize that the early clinical presentation of acetaminophen, of a toxic acetaminophen ingestion, is asymptomatic. And we know that people who come in after ingestions, intentional ingestions, 1 out of every 500 have a detectable and treatable toxic amount of acetaminophen, even though they said that they took something else. So this tells us that we should make sure that we draw acetaminophen or a paracetamol level on all patients who come in for a suspected overdose. And again, the mechanism is that it produces a substance called NAPT that leads to ultimately to liver toxicity. And in the acute ingestion, we use the nomogram to determine whether or not a patient needs to be on the antidote, which is going to be N-acetylcysteine, which can be given both IV or orally. So going back to this, we want to make sure that we stabilize the patient with airway, breathing, and circulation. But in terms of the diagnosis, that is up to the clinician at the bedside. Right? That is that's looking at the vital signs, that's looking at your physical exam, and that's going to help you determine ultimately the class of drug that might have ingested, and then how to appropriately take care of them after that. Now, last thing is making sure that they get charcoal for those who are able to, and then hopefully to get a tox consult, call the SPY at the Nepal Center to get some additional help. So things that you can do at the bedside to help us is determining time of ingestion, finding any empty bottles, determine the milligrams per kilogram dose if possible, but mostly, like I said before, a good physical exam to determine that class of ingestion. And thank you very much. And I guess we'll take questions either now or later.
Thank you, Dr. Olano. That was an amazing lecture, and really good overview of what we must really consider when we see a suspected case of poisoning. A really good guidance. We will have this lecture recorded and posted on our YouTube channel that we'll share with you in a bit. So for anyone that missed it or wants to share it, I know some people want to record it too here, but I have it recording, so we'll share that. We'll save questions for a little bit later, if that's okay, Dr. Olano. And
Absolutely.
we'll have our next speaker speak. Can you, Dr. Rakesh, you can go ahead and start sharing. And I will give an introduction of Dr. Rakesh Ghimire, who is our next speaker. So Dr. Rakesh Ghimire is at TUTH. He is an assistant professor in the Department of Clinical Pharmacology, and he has a MD in Clinical Pharmacology from the Maharajganj Medical Campus at TUTH. Dr. Rakesh Ghimire's expertise and interest in research revolves around clinical pharmacovigilance as well as clinical toxicology, mainly focusing on pesticides-related poisoning. He's been working with pesticide suicides for more than 5-6 years. He has worked with the regulatory stakeholders to lower the suicide burden, from pesticides in Nepal. He's well published in this. He is actually currently in Kerala, joining a conference in toxicology. So we're very excited to have him speak about the status of pesticide poisoning in the country. And just for you guys to know, he's also one of the core team members of our sort of founding members of our Poison Information Center and a core faculty in the National Expert Advisory Group. So without further delay, please welcome Dr. Rakesh Ghimire.
Thank you very much, Dr. Ramu. Such a nice introduction. So am I audible to everyone?
Yes, you are.
Okay. So namaste and good evening to everyone. I'm Dr. Rakesh Ghimire. My introduction has been done nicely by Dr. Ramu. Thank you so much. So today, Dr. Ramu has talked about the PIC and Dr. Jonathan has talked about the management of the pesticide poisoning. So I will briefly go on what's going on, the burden of pesticide poisoning in the country and what has been done and what is being done to decrease this burden of pesticide poisoning in the country. So before I start my presentation, I would like to go briefly on the story of, sorry. Oh, my slide is moving or not? Is it moving, my slide?
It's not moving.
Oh, it's wrong. Okay.
Now it's moving.
So, yeah. So, so before we go to the problem and the burden of the pesticide suicide, so I would like to go briefly on the story of an 18-year-old girl. So she walked into the emergency department with the complaint of shortness of breath, and she was saying like, "Doctor, I am having pain in my throat. I have difficulty in breathing." So a doctor who was in charge in that emergency department assessed the patient, and soon after she landed in the emergency department, she started having the nausea and vomiting, and then the history was taken from her husband and then her husband told that she had ingested the pesticide, which was brought in their home for the control of the pest. So she has taken the pesticide after the minor discussion with her husband. So and then based on the toxidrome and the history of the patient, we gave the early antidotes. So it was the organophosphate poisoning, and then we gave the atropine. So it was in the primary healthcare center, so we didn't have the sophisticated other treatment modalities. That's why we referred the patient to the tertiary care hospital. And then we follow up the patient next day, and one day after the admission in the tertiary care hospital, the patient died. The reason she died was she had ingested highly toxic pesticide. So, and then this pesticide was bought in their home by her father-in-law to protect the pest in the vegetable. And she had a very easy access, and it was stored in the storeroom that she had easy access when she had a discussion with her husband. So from that day, so this is the real story that I had faced when I was working as a medical officer in one of the primary healthcare center back in, like a decade ago. So from that day, it came in my mind, like it was coming back and again that what if that highly hazardous pesticide had not been, produced in the market, or it's manufactured by in the market, and it's in the market. And then again, what if we had the standard treatment guidelines which updated and the proper training to the medical healthcare professional on the management of different poisoning. And again, what if she had not that access to that highly hazardous pesticide? So that's when my interest was working in the pesticide poisoning grown up. And I'm here talking on the like the burden of pesticide poisoning in the country. So let me talk about what I have done so far. Like I have been involved in the pesticide-related self-harm and trying to save life by regulating and doing research and by regulating this highly hazardous pesticide for the last year. I have been involved in this for the last 10 years or so. So I have been involved with the Professor Michael Stone, who is one of the pioneer in doing research in this pesticide self-harm, and his work has saved many lives in the Sri Lanka and Bangladesh. So we're trying to save life in Nepal as well. I would like to talk briefly on what we are doing in saving lives by regulating this highly hazardous pesticide in terms of working with the Ministry of Health and Population, as well as with the Ministry of Agriculture and the Livestock Development. So, going back to the story, that was the story of an 18-year-old girl. There's many such story in the country. So yeah, if you see the problem of the suicide in the country in the year 2022 and 2023, 6,993 deaths were from suicide, which was almost similar from the year before. And of these suicides, 80 to 20% of death were due to poisoning. And if you see the graph, this was the data we have published the data in one of the paper in the PMC journal. So in this graph, you can see that from the 1980 to 2022, you can see the increase. The one with the blue dot line represent the suicide due to hanging, and followed by the, if you see the green dot line, that shows the deaths due to suicide due to poisoning. So over the period of time, like, from 1980s to 2022, there is increase in number of suicide in the country. You can see from the graph. Again, there is increased number of suicide by hanging, and the second is poisoning. And if you see there, the pesticide ban had happened in the year 2020. And from that time, looking at the data of suicide, we can see the decrease in number of deaths due to poisoning. So poisoning is the second most common methods of suicide in the country after hanging. And of these poisoning, most of the deaths were due to the pesticide poisoning. So there is a problem. We all know there is a problem. What is the solution now? So deaths from pesticide poisoning is preventable, and there are evidences, various studies has been done in different parts of the world that if we can restrict the access to these highly hazardous pesticides, can help in prevention of these suicides due to pesticide poisoning. So if you see the example of the Sri Lanka and Bangladesh, are a very good example. Following the ban of these pesticides, which is highly toxic pesticides, has led to the decreased number of suicide in the country. But still, it requires the involvement of the multi-stakeholder, and it should be in the multi-level. It's a tiresome work, but it's doable. So to prevent this suicide, early detection, identification of pesticide involved is mandatory, and which is quite challenging in our country because we don't have that recording system and reporting of the poisoning, as you can see in the picture that this is our this was from our project we did a few years back, and she was our data collector, and she went to one of the government hospital in the country, and we look at the status of the data. It's very difficult to get the actual data. So one of the solution would be improving the poison recording and reporting. So how we can do that? So based on the different studies and that what we have encountered so far, encouraging the hospital for the use of electronic medical record could be one of the solution for improving this the poisoning related data. And again, as Dr. Ramu has mentioned in his first presentation regarding that government had mandated the establishment of the government-owned National Poison Center. And that would also help in identifying the pesticide involved, and then that can be regulated in some time. So furthermore, proper training to the healthcare professional in the management of various poisoning is very important, because the toxicology field in the country is far behind. So we don't have the clinical toxicologists as of now. And this is not new to our country as well, because now I'm here in Kerala in the Asia Pacific Association of Medical Toxicology Conference. So here also I have met a few colleagues from different Asian countries like Japan and then Malaysia, but still they don't have the clinical toxicology much, and there's a scarcity of the medical toxicology in our part of the world as well. But still, I think we are far more behind. Nepal is far more behind, and we need to have the proper training, and we should have some training, like the course on the management of various poisoning, starting from the medical officer and then going forward. And availability of the updated standard treatment guidelines is also important. So we have standard treatment guidelines, and it's not updated, and it's been a long time. So there should be an updated standard treatment guideline to various poisoning. So for most of the poisoning, if there is the availability of the antidotes, then we can save lives. So it's also important that there should be a sufficient availability of the antidotes to various poisoning from the primary healthcare centers to the secondary healthcare center and so forth. So I'll talk briefly on this. I think this is not the scope of this presentation, but still I would like to give an overview of what's going on. Like, there is a burden, and we know the solution, And then what's going on the regulation of this pesticide? We know poisoning is the second most method of suicide in the country, and pesticide is the most common among the poisoning. So what is being done by the government, and what's going on the regulation? So I have been involved with this regulation for the last 6-7 years. And then, so that's why I would like to share my experience, what's going on. So between 2001 to 2019, 24 pesticides have been banned in Nepal. So in 2019, August, 8 pesticides were banned. And if you see here, it was this is a study done by us. This is one of the with a large sample size. We had almost 4,000 sample size in this study, and we published this in the clinical toxicology journal. So and from this study, we found that 2 problematic highly hazardous pesticides, which were responsible for the majority of deaths due to pesticide ingestion. So that were the dichlorobus, which is the organophosphorus compound, and the aluminum phosphide 3-gram tablet, which is the phosphinic gas. It releases the phosphinic gas, and it leads to the multi-organ failure. So after this recognition of these 2 problematic highly hazardous pesticides, we call it as the toxic pesticides. We presented the data to the national regulator, which is the Pesticide Management Center under the Minister of Agriculture. And then they realized the importance, like the burden of this deaths due to these 2 pesticides, and they banned the pesticides in 2019, this dichlorobus and aluminum phosphide tablet. So this is good news that looking back on the now we are looking at the impact of these bans, and we are seeing that there is decrease in the number of suicide following the use of these dichlorobus and the aluminum phosphide, which is good news. And we can say that there is an effective implementation of this ban and leading to the deaths, decrease in deaths due to this toxic pesticide. So there are different sources for the management of pesticide poisoning. So these are the different articles. You can always refer to the article that we had published in 2016 on the management of organophosphorus poisoning. And there is also another publication on the early management after self-poisoning with organophosphorus or carbamide poisoning. It's a treatment protocol for the junior doctors. And there are many other resources which we will be sharing with you in a time being. If you're interested, please let us know. As Dr. Ramu said, like I'm right now in Kerala. I'm attending the Asia Pacific Association of Medical Toxicology. It's a very good place to networking with the different people across the globe who are involved in the toxicology field. You can see in the middle the one with the group photo. So these are the people from Malaysia and UK, New Zealand, and Australia, and different parts, and they are running the poison centers. And Dr. Ramu, it was a very good opportunity for us to learn from them that how they are running the poison center, and it's a good opportunity for us to have them on board for their suggestion in going forward with our project. So you can see on the right side the guy who is the Professor Eric Nook Hobda. So he's the man. If you see his article, he's the man who is working in the methanol poisoning for the last 20 years. And he is ready to be our international expert in helping us answering the queries related to the methanol poisoning in the days to come. And I would like to thank Dr. Ramu. Because of him, I was able to meet Dr. Mark Su. You can see in the right side and the left side, Dr. Hopeman. Dr. Ramu helps me in connecting with those people in New York. I was in US last month, so I got an opportunity to go to the New York Poison Center and meet them in person and get to learn lots of things regarding how effectively we can run the poison center in the country. And the Gold-Frank toxicological emergency, you can see in the left side, the right, one of the writer, Professor Hoffman. So it was an opportunity to meet him in person there, and he has donated the Gold-Frank toxicological emergency book to our poison center. And yeah, this is it. That's what we have been doing so far. So I would like to thank Dr. Ramu, who has initiated this work in Nepal, and on behalf of our Department of Clinical Pharmacology, we're always there to support Dr. Ramu, and I would also like to thank Axe Foundation, who are supporting us with the logistic thing. Thank you all of you, and thank you all of you for your kind attention. Thank you.
Thank you, Dr. Rakesh. That was a really enlightening presentation and really good for us to know that, Poison Center is not just about medical toxicology help, but rather also there's a lot of policy involved, there's a lot of education involved, there's a lot of research involved, which we hope that this center will allow for our country to help better manage our poisoning patients. So I want to open this time before I move on. We're going to have Dr. Anjali take over the moderation in a second, but I want to open up question and answers right now if anyone has any questions. And feel free to either write on the chat or you can unmute yourself and speak. And please show your videos also if you can. So you can ask about specifically Dr. Delano had to go back to his toxicology clinic. So if there are any questions for him, I can forward him the message and we'll get back to you through email. But if there are any questions just about this Poison Center and how this runs or anything else, please go ahead and ask. All right. It looks like no questions, so that's fine. And now I'll just sort of briefly conclude with this. You've heard about the Poison Information Center. So remember, this is the first institutional Poison Information Center. We do want to appreciate people that have worked in this field, especially Dr. Sam Lohani, who has been working in this field for a long time in Nepal. So we hope that him and his team can join us in making this center institutionalized. That's one of our goals. A second thing, we have social media accounts, so you can go to our social media account. What we'll be doing on a daily basis almost is our specialist will be posting about at least some toxidrome, right? So you guys can use this as a learning platform for yourself. So we'll have a lot of educational material, any lectures coming up, webinars. We're hoping to do monthly webinars with experts, international experts on different topics. Please follow. So there's a Facebook page, there's Twitter, there's Instagram. So you can go ahead and follow those. And then if nothing, please take this phone number down. I already gave this phone number earlier, and then please share it along your network to doctors, because we have this center, so it needs to be utilized. If it's not utilized, then it might be difficult to keep this running, right? So please use the phone number and the center. And now I'll end with, and I'll let Dr. Anjali come through here. I'll end with thanking a few folks. First, I really have to thank our specialist spies. These are the first spies of the first institutional Poison Information Center. Our lead spy is Dr. Rajesh Sharma Podil. He's also here, and they've been working really hard over the last year, to sort of try to set this up. So we're really proud of Dr. Rajesh. I also want to say Dr. Ayushma Pandit, who is also here. She's our another spy. She's also been working really hard. And then is Dr. Rishika here or no? Dr. Rishika is also probably here. She's our Dr. Rishika Karki. Are you here? Yeah, I think she's here. She's one of our third spies. So these are the third spies. They're trained very well. So I want to thank all of them for their hard work. And then I want to thank our ASK Foundation team, who has worked really hard in the background. Dr. Yagya Timilsina, who is here, he's sort of part of ASK and sort of leading the efforts from ASK and in helping us coordinate. We have Kabin Maliku, who is a pharmacist, I don't think he's not here right now. And then from ASK, Dr. Prabhat Adhikari has also been helping on the side. And then we have Anjana Thapa, who is a bachelor's of public health student that joined after her public health degree, and she has been key in helping us sort of coordinate all this. So I want to thank those people. And then finally, I think from the TU and Dr. Anish Marwadi, who is the head of department at the clinical pharmacology department. I don't know if he's here, but we want to thank him for coordinating. We want to thank the dean of TUTH, and we also want to thank Dr. Pradeep Gewali, who was at NHRC and and in the clinical pharmacology department who has been helping, and all the other faculty at the clinical pharmacology department. So thank you so much for helping us coordinate this. We're really happy of how this is going. I'm sure there's a lot of names I have missed, so I don't want to belabor the point, but there are a lot of folks at Brown, at Emory, that have helped us move this forward. So please, guys, use this number. I'm going to just leave you with this last picture. This is a picture of my bhanja, recently born. So I'm about to see him in a few days, so I'm very excited about that. Isn't he cute? His name is Kion, for anyone. Okay. Now, Dr. Anjali, are you here? Oh, there are questions. All right. All right. Role of PAM in organophosphate is controversial. That's a great question, Chitiz. It is controversial. I'm going to defer this question to Dr. De Olano so he can get back to you. Management of intermediate syndrome. I'm going to defer this to Dr. De Olano also. I wish he could have stayed for this question answer, but we're going to send this to you guys. I know the answers to this myself, but I'm not a medical toxicologist, so I want a toxicology expert to answer these questions for you. So stay in touch with our WhatsApp group and social media, and we'll help answer those questions. Any other questions before we move on? If not, please, Dr. Anjali, you can take over.
Thank you, Dr. Kharel. Ladies and gentlemen, thank you for your active participation and engagement in today's enlightening discussion on poisoning. It has been an incredible journey, and we hope you've gained valuable insights and practical knowledge to enhance your ability to deal with poisoning cases effectively. Before we conclude, I would like to express our gratitude to our distinguished panel of experts for sharing their expertise and experiences. Your contributions have been invaluable, and we appreciate your commitment to advancing healthcare practices in the context of poisoning. To all our attendees, as healthcare professionals, you are at the front lines of patient care, and your dedication to preserving and improving lives is commendable. We trust that the knowledge and insights you've gained today will make a difference in your daily practice. Now we have with us the Nepal Medical Association Executive and Joint Coordinator, Dr. Tetsu Singh Malla. I would like to request him to provide closing remarks in today's session. As we close this webinar, let's carry the knowledge.
Thank you, Dr. Am I audible?
Yes, you are, sir.
Hello.
Yes, Dr. Tetsu, go ahead. You're audible.
Okay. Thank you so much for a very wonderful presentation, and it was nice knowing about the Poison Information Center, as well as all the eminent speakers. The presentations were very nice, and I think we should have this kind of presentation very frequently, because it's a very important topics, and with lots of shortage in treatment and medicines and manpower in Nepal. I think this kind of information will help a lot. And I think those participants have also gained a lot of knowledge regarding this. And we look forward to have this kind of programs virtually and physically in future as well. And I would like to thank Dr. Vikas Sitola, our coordinator of NMA JDC, for involving Nepal Medical Association and all the faculties involved. Thank you.
Thank you, Dr. Malla. As we close this webinar, let's carry the knowledge and skills that we've acquired today into our workplaces, and together we can make a significant impact on patient care and safety. Thank you for your dedication to the well-being of our communities. Until we meet again in future learning opportunities, stay safe and stay informed. Goodbye and take care. The webinar has officially ended for today. Thank you.
All right. Thank you, everyone. Bye-bye.